The following is a procedure called lithotripsy, where we break up kidney stones. As you know, the kidney stones are usually found either in the kidney or it could be in the ureter, the tube between the kidney and the bladder. The latter situation will cause a lot of pain. So usually patients present with severe pain in the flank, going from the back to the front towards the groin area. That will usually signal a stone in the ureter, but here is a procedure we're going to show you where the stone is in the kidney, and this patient has consented very kindly to be photographed, and so is my technician here. We are working at the surgery center in Antelope Valley. This is the machine made by Karl Storz. It's a lithotripter. The tabletop moves in the X, Y, and Z axis as the technician is showing you there. And on top you have this membrane which the patient's body will be situated on, especially the kidney area, and you can move the patient in these different axes to locate the stone at a point called F2. Now the treatment head is coming up underneath the patient. Between the patient and this membrane we put some water because the shock wave has to travel through a medium, otherwise it's not going to hit the stone. So here the shock head is going up and hugging the bottom of the tabletop. So that'll be in contact. Now the shock wave will go right through that expanding part of the treatment head and through the table bottom, and the shock wave will come to a point and hit the stone at point F2. So we get that stone right at the middle to locate it in the right position. Here he's showing the fluoroscopic images, and we take several images and we can hit on one and then zoom in, and here the stone is located. That's the dark structure in the middle, and that's what he's pointing to. And we do it in crosshairs. So here again, this is a different oblique image. Once we got it situated in the correct position, we start the treatment. And the treatment consists of several shock waves. Usually the FDA only limits us to use about 2,400 shocks safely. Sometimes we make the decision that the patient could tolerate some more, and if the patient is on blood thinners and has to have the procedure, I don't even do the 2,400 shocks. I may stop at 1,000 and bring the patient back. Here's an EKG monitor that we use. The shock wave can be gated, meaning it goes on the R wave of the QRS complex of the EKG. So that it will prevent premature beats of the heart. So here we can switch the shock waves from a regular rhythm to coincide with the R wave of the QRS complex. And you see the counter there as well, and you can see the shocks occurring corresponding to the heartbeat. Here his patient has had 730 shocks and going up. This patient, I think we gave him a total of 2,400 shocks. He's pretty small. Not a heavy patient. The stone was fairly dense, and he did very well with the shockwave treatment. The patient is very comfortable. You can see the bottom of his back right there, the shock head right against it. A nice view. Rarely do you get this kind of a picture. And here he's looking at the progression of the lithotripsy treatment. The stone is not as dense anymore. You can see it much lighter. That's because the shock wave breaks up the stones and it's between the stone fragments. So initially, when the stone is not fragmented, it looks very dense and dark. And as the stone breaks up, it becomes lighter because the particles move away and actually they look bigger. The spot size gets even bigger. And here he's showing the stones are breaking up and spreading upward towards the collecting system. And if the patient is given lots of fluids and an injection of a diuretic called Lasix during the end of the procedure, it will help get the stones out. See, the stone treatments depend on the patient, number one, and the location of the stone. If the stone is in the kidney, like in this particular patient, we do the lithotripsy for the kidney stone. If the stone is in the ureter, we just move that shock head to the position of the ureter, which will be closer to the midline between the kidney and the bladder, and the stone can be located and treated. If the stone is in the mid part of the ureter, which will be overlying the bony structures like the pelvis and the sacrum, then you cannot shoot the shock wave through the bone, in which case the patient will have to lie prone with his face down so that we can get at the stone from the front of the abdomen. So you have to decide how to position the patient. This patient was on his back. That was the closest part for getting into the kidney. If it's in the lower ureter, close to the bladder, we could also use lithotripsy procedure where the patient will be pushed up towards the head of the table and the pelvic part will be on that membrane. Also, the lower ureter stones can be treated in a different way, where you can go up the ureter endoscopically, meaning going through the urethra into the bladder and up the ureter, and expand the ureter to make it a little larger and get a ureteroscope in to grab the stone using a basket. This patient came back a couple of weeks later to my office with a bunch of stones. I think you're going to see some fragments photographed, and we're going to put that right next to the image of the stone before treatment to show you what happens to the stone after it is shattered and passed. We always send these stones out to be analyzed. Most often the stones are calcium oxalate stones, and they can be treated in a certain way. And if they're uric acid stones, we have a problem seeing them on the fluoroscopic images or x-ray. We may have to give them some intravenous or contrast through the ureter to make a filling defect or create the image so that we can actually see it as a negative image on the x-ray to treat it. Most stones are formed because patients don't drink enough water. When we do a 24-hour urine analysis, which is a follow-up for stone treatments, patients come back and we want to know why they made the stone. So we have them give us stone fragments for analysis, number one. Number two, we do a 24-hour urine analysis where they collect all the urine they make for a whole day, send it out to a laboratory, and they send back results. That'll tell me how much urine they made per day, how much calcium is in the urine, how much uric acid, how much citrate, oxalate, etc. Patients that make stones seem to be, number one, most commonly they don't drink enough water, so the urine output is low. So the treatment is pretty simple. Just make them drink 2 liters or more water every day. There are also certain protective factors in the urine, like citrate, which needs to be elevated in your intake, or you need to drink more citrate, either in the form of concentrated lemon juice and water, or you can take citrate tablets to increase the citrate levels in the urine so that you're protected from making kidney stones. We often see patients with an elevated amount of calcium or uric acid, and this may be corrected by altering the diet to a lower calcium diet or a lower uric acid diet. Occasionally we also use medications like hydrochlorothiazide, diuretic, which helps excrete the salts in the urine. So the treatment really is different for each patient depending on the 24-hour urine analysis result. We do let the patients know that once you make stones, there's a good chance you're going to make it again. So we encourage them to get that 24-hour urine analysis back to us. We do one, and then we put them on a treatment plan and recheck the 24-hour urine analysis in a couple of months, 2 to 3 months, to see if a treatment is indeed successful. So that's the story about kidney stones. How do you treat it? And thank you for listening.